Hello and welcome to the Fluid and Electrolyte lecture. Start with talking about fluids briefly. I don't have a lot to say about fluids, and I assume you get some fluid management in other classes. It's more or less a standard operating procedure when you're evaluating a patient of assessing their fluid status. Hopefully this has been talked about in ClinMed and other places. And from a medication perspective, I don't really consider fluids medications, but you'll often order them the same way you will order medications. Like if you're working in the hospital, usually fluids are part of standard order sets and things like that. So you can just kind of check the boxes of what you want. But there's a couple different fluids out there. The major ones are going to be either saline or dextrose-based solutions. The normal saline is probably going to be by far and away the most common maintenance fluid you give people. We use dextrose more often for compounding IV medications, so whether it's an IV bolus medication or a continuous infusion, dextrose tends to be the solution we're using as our fluid there. The reason is a lot of drugs tend to be a little bit more stable in dextrose. Now, we might actually switch people to saline if, for example, they have issues with blood sugar, glucose control, and can't handle the extra dextrose. We might try and switch them. And in fact, we have actually switched a number of our base solutions as we've been able to saline just because of that, because we get so many requests to minimize dextrose, and so it just creates complications. But you might notice certain things will be in dextrose, and that's often because that's the way either we know that they aren't stable in normal saline. So if you mixed a certain drug with saline, it might cause a precipitate, which could be dangerous if you infuse that into somebody's bloodstream. And then the other thing might be that the manufacturer simply just studied it in dextrose and they published that, and we don't have any data to support anything else. There's a number of variations of fluids too. There's half normal saline. There are combination fluids like D5 normal saline or D5 half normal saline. There's lactated ringers, which I'll show you what that is on the next slide here in a second. But basically they're all the same thing more or less. You don't really have to use the odd ones in normal scenarios. We really only use these for the only time I can think of is sometimes when you're doing maintenance fluids and you want to add potassium to them. You might use like a D5 half normal saline and then add potassium to it to make up for the tonicity there or something like that. But the point is that you don't use them very commonly. It's not generally something you would order for a patient, so don't worry about too much. Lactated ringers has been getting more popular in certain patient populations. It's commonly used. So for example, in OB patients, lactated ringers is always the fluid that's given. For whatever reason, I'm not entirely sure why. OB is kind of I always think of it as a little bit of an oddball compared to all other types of medicine, because they have sort of a standard set of practices based on long-standing evidence, which is good, but a lot of the stuff hasn't been changed or challenged in decades, and not that it needs to be, because it's probably still fine and likely is, and certainly they have new things coming out all the time, just like other areas of medicine, but they have kind of odd things, and lactated ringers is one of them associated with obstetrics. For some reason, that's the fluid they like to use. Anyway, sometimes we see this actually used in ICU patients. There's been some traction for patients with sepsis or other complicated advanced diseases that lactated ringers is better than normal saline, but the jury's still out on that. So it's probably going to be provider specific. And honestly, I wouldn't worry too much about it. Colloids are a little bit different. So colloids are going to be bigger, bulkier molecules. So albumin is an example of a colloid, which is just a human protein isolated from blood products, purified down into albumin and then infused. And these products basically just change the concentration gradient. So they keep fluid within the intravascular space. And that can be helpful for a number of reasons. Albumin's by far the one that's used most often. The other ones, hetastarch and dextran, are things you can infuse, but they're mostly just like non-soluble polymers that you could infuse into somebody that don't do anything. They're just inert. And again, they kind of have the same function, but albumin's the one that's used often. A great example of when you might use albumin is if you have a sudden loss of blood. So, for example, we stock albumin in every single OR because if you have a loss of blood during a procedure, you have some time before you can actually get real blood products like plasma or actual blood in to replace that. So you can push, a half liter, a liter of albumin fairly quickly and get that, right into the patient. And that's going to be a nice bridge until you can replace blood if you need to, or until you can replace or fix the bleeding problem, I should say. Colloids are much more expensive. Any human blood product purification is going to be pricey. Albumin is very expensive, but it does have a role. So we aren't going to use it, as a standard maintenance fluid ever, but it certainly has its place in therapy. I say not superior to crystalloids here, and that means just because these are crystalloids, by the way, versus colloids. Not superior to crystalloids means that if you're just replacing fluids, they're not superior, but certainly in situations like what I just said, albumin is going to have a superior use to crystalloids. It's just more of a specialty thing versus a common fluid replacement. This shows you the differences in pHs and what exactly is in each of the solutions. I'm not going to test you on this, but for example, you can see LR here is lactated ringers, and just what the difference is. The pH is a little bit higher. You have more of a balance. You have a little bit of potassium, a little bit of calcium, a little bit of lactate. So it's a little, again, it's probably the most different out of all the ones we're looking at here. All right, that's all I want you to know about fluids. I'm not going to test you on replacing fluids or anything like that. We'll talk about fluids a little bit more when we talk more detail about sepsis next summer, but other than that, that's all. I just wanted to bring that up quickly because we're going to talk about some replacement fluids here in general terms, like replacing sodium or potassium or things like that. Okay, so sodium disorders are primarily related to the patient's hydration status. And what's going to happen is if sodium shifts, you're going to see a larger change in cell volume. So water follows sodium, or sodium follows water. What's the right way to say that? Anyway, they move together, and you have a system that if your sodium gets out of balance, if it goes very low or very high, your body's going to try and compensate to make up for that. So if your sodium's depleted, your body's going to try and get rid of fluids to increase the concentration of sodium. And if it is really high, it's going to try and retain fluids so that you dilute out the sodium more. So it'll work that way in the kidneys, but at certain points that could be problematic, and you can only sustain that process for so long. If you do have a rapid shifting of volume, especially within the central nervous system, you can get significant brain damage, and that's the biggest issue here with sodium, and specifically wasting sodium. So for hyponatremic disorders, if that happens fast, that can cause significant symptoms, specifically altered mental status and even brain damage in some cases. So hyponatremia is the more significant of the two. Hypernatremia is rare. We'll talk about it quickly, but hyponatremia would be a sodium, generally speaking, a sodium less than 135, mostly concerning among elderly and neonates, but it depends on the patient and, depends on the presentation. So you're usually ask yourself three things with most electrolytes apply to this. How low or how high, I should say. In this case, how low is the sodium? How acutely did it change? And what's the patient presenting like? Mild symptoms would be lethargy, maybe some muscle cramps, really non-specific stuff. I mean, this could define any number of syndromes. So you wouldn't really know this was caused by sodium unless you got a sodium level. And generally speaking, everyone who comes in who's going to get some labs done is you're going to check their sodium, in addition to several other things on a standard Chem 8 or whatever you're running. Severe symptoms, again, I talked about altered mental status, so confusion, agitation, disorientation. I've seen actually patients who almost present in like a schizophrenic-like mindset where they're paranoid or they're having some hallucinations of sorts, and they have no history of mental illness. So that's a real key that hyponatremia is causing this. So certain causes of hyponatremia. If you give somebody extended dextrose infusions without added saline, you can dilute your serum sodium over time. So that's why we don't really ever use D5 as a maintenance fluid. There's really no reason to. If you just give somebody normal saline, you're going to keep their sodium right where you want it. Hyperglycemia can cause hyponatremia, and the reason being is that increased in serum osmolality causes water to be pulled from the intracellular space to extracellular, and where sodium follows water. And then it's the same with if you gave somebody like a mannitol infusion or a radiocontrast dye. So those are some things to watch out for that can adjust the osmolality and cause water and sodium to move around where you don't want it. Serum sodium decreases by 1.7 per 100 milligrams per deciliter of blood glucose increase. So if you can actually do a calculation. So the point here is that if you have somebody with a really high blood glucose, their sodium you're going to see on their lab report isn't going to be the actual sodium. So you actually have to do a corrected calculation. And a lot of places will do this for you, but it's just something to remember that if they have a really high blood glucose, you look at their observed blood glucose minus 100, which is what we'd consider normal, divided by 100, and then times 1.7 gives you your expected sodium decrease, and then observed plus expected gives you your corrected sodium. So with that in mind, that's how you would see what your sodium actually is, which would be different than what the lab would report to you. Now these two things aren't going to likely cause symptomatic hyponatremia, and D5 infusions are likely not going to happen at all. And hyperglycemia generally doesn't get bad enough where you see profound hyponatremia. So it's certainly a cause, but not as common. More serious causes are going to be things that drop sodium very quickly. So diarrhea, dehydration, diuretics. Those are probably the big three to think about. These are going to cause hypovolemia, and at the same time, they're going to waste sodium. So they aren't just wasting free water. The sodium's going out with it. CHF, nephrosis, hepatic cirrhosis. These patients will be hypervolemic, and that just means that the serum sodium is diluted. And then renal failure, SIAH, which is a syndrome of inappropriate antidiuretic hormone, and polydipsia cause isovolemic status, or would be an isovolemic example of what would cause a decrease in sodium. So remember, consider your rate of decline, severity of your current symptoms, and aggressive sodium replacement in clinically serious scenarios. So anytime a patient, I kind of draw that clinically serious one at these symptoms. So any altered mental status with low sodium, even if it's just slightly low, that would be a cause for wanting to replace pretty aggressively. And of course, if somebody's seizing or in a coma, that would obviously be something you'd want to be very aggressive with. Okay, so when we're replacing, if it's not critical, generally speaking, you can just fluid restrict or give oral sodium first, depending on their presentation. If they're hypovolemic, you just replace the fluids with normal saline. Normal saline, if we go back to this little chart here, the sodium concentration is 154 milliequivalents per deciliter, and so that's a little bit on the high side of what you would want in your serum concentrations. But sodium can go from 135 to 155, 160 within normal limits, so depending on the lab and what they're accounting for. But the point is that if you gave somebody normal saline, eventually it's going to correct them gradually up to a higher point within the normal limit, and so that should take care of most of the problem. If there's an offending agent, that's something we'd want to hold as well. So specifically diuretics. Talked about thiazide diuretics. Obviously loops can waste a little bit of sodium, but I think about thiazide, specifically chlorothalidone, being the big red flag for dropping somebody's sodium aggressively. If somebody's critical, you're going to use hypertonic saline. So just the difference between normal saline and hypertonic. I guess I had it right here. I didn't have to go back to all the slides. Sorry about that. You can, the problem with hypertonic saline is that if you do it too quickly, you can shift fluid back into cells or out of cells, and you're moving stuff around, and those changes can cause cell damage, specifically in the central nervous system. Just like the drop of sodium is causing damage, increasing the sodium substantially in a quick amount of time will have the same adverse effects. So we want to monitor very aggressively with hypertonic saline. Hypertonic saline is considered an extremely high-risk medication, and usually you want to check sodiums probably every hour at least while you're replacing. And I would generally recommend unless the person's comatose, be on the conservative side of your hypertonic saline infusion. The general recommendation is you want to avoid exceeding an excess in serum sodium of 12 milliequivalents per liter in 24 hours. So that's sort of your rate you want to look at. So if you start replacing with hypertonic, you recheck their sodium and it's gone up by like 5 in an hour, that's probably too fast. You might want to ratchet it down a little bit. And again, I just can't stress this enough. This is something that we give regularly, but you have to do the correct monitoring and you have to watch it carefully. Deficit calculation. I'm not going to go through this calculator. If you want to play with it, you can. This is on Global RPH. I just think it's a pretty decent calculator. You can mess around with different numbers and parameters. What you're going to find is that it generally recommends starting people around 50 mils per hour or something like that, maybe 25 on the lower end. That's a good thing to remember with this. I'm not going to test you on that for sure, but if you're ever like, well, there's some really complicated sodium replacement calculations out there which aren't worth wasting your time with, just consider kind of starting at 50, 25 mils per hour, somewhere in there, depending on how aggressive you want to be, and then you can titrate from there. Okay, I mentioned SIAH quickly before, and we'll just talk about it a little bit more detail now. It's syndrome of inappropriate antidiuretic hormone secretion, which basically means you have too much antidiuretic hormone floating around. This can be drug-induced, so there's a couple products out there. Desmopressin is basically synthetic ADH, so that's gonna, if you took too much of that, potentially you might see that. Phenothiazines are certain antipsychotics, antiemetics, and antihistamines fall into this category. SSRIs are serotonin reuptake inhibitors used for depression commonly. And then some other drugs, carbamazepine, the chemotherapy cyclophosphamide, chemovincristine as well. Treatment, if somebody does have SIADH, you want to fluid restrict, increase your sodium intake. Consider your hypertonic saline option if you need severe replacement, or you need, like quick replacement. Loop diuretics can help get rid of free water, which can help out a little bit, and vasopressin receptor antagonists are an option too. So VRAs are kind of a unique class of drug that end in vaptan. There's, I think, only two on the market, conivaptan and tolvaptan. These aren't really common medications, so honestly don't spend a lot of time on these. All you need to know about them is that they're used in more significant cases of SIADH or hyponatremia that's not responding to other things. So your mechanism of these drugs, what they do is they promote free water loss without sodium loss via decreasing collecting duct permeability to free water. Essentially, they kind of are a sodium-sparing diuretic. That's an easy way to look at it. They come IV. You give a loading dose plus a 24-hour infusion, max duration of 4 hours. Risks, they can overcorrect sodium, especially if you have hypertonic going at the same time, which sometimes you might if you have a patient in really severe hyponatremia. They're super expensive, especially compared with your alternatives of just giving somebody hypertonic saline, which is cheap. There's acute role only, and honestly, they haven't really been proven to do better than standard therapy. So certainly, these fluid restrictions and increasing your sodium intake are going to be your big ones you're going to try. Loop diuretics are a cheap way to get rid of free water. They're going to waste some sodium, and you're going to have to manage potassium and things like that too. But the VRAs have a role. They're just a limited role, mostly based on their cost and their extreme risk of causing a hypertonic scenario. Okay, hypernatremia. Again, I said this was quite rare. It's usually mostly caused by severe dehydration, rarely by increased sodium intake. Generally speaking, our kidneys can tolerate a lot of sodium and we can excrete whatever we don't need. But if somebody's kidneys are failing, you might see that as well. So somebody with advanced CKD. Mineralocorticoid use can cause this, and diabetes insipidus can cause this as well. It's less common. Again, I don't think I've ever seen a clinically significant hypernatremic patient. It's just really odd. High sodium is indicative of cerebral cellular dehydration, so you can also have problems with the central nervous system. That's probably going to be your major causes. They're going to be really similar, actually, to what you'd see with a hyponatremic patient. So if they're volume down and they're hypernatremic, so if this is a dehydration case, you just want to rehydrate and restore that intravascular volume. That's it. As you're rehydrating, you probably want to avoid using high sodium containing solutions, so maybe like a D5 half normal or something like that might be a good idea. But you don't want to dilute it too much, so even making sure you're switching to normal saline at a certain point is really important. So monitoring is key, making sure you're watching that sodium every half hour, 2 hours at least. If the patient's fluid overloaded, a loop diuretic should work. It should waste free water without wasting sodium. However, you are going to get that potassium wasting and other ion wasting as well that you got to watch for. If you have diabetes insipidus, decreasing free water and considering desmopressin. So we just talked about desmopressin, which you can overdo that, but again, it's basically synthetic antidiuretic hormone. You can give it orally or nasally, and that'll work for this particular scenario. All right, potassium. Potassium's the most significant electrolyte when it comes to clinical severity of symptoms and what you might see with potassium. The reason is potassium is responsible for a number of things, and the biggest problem with changes in potassium are going to be cardiac tissue conduction and arrhythmias. Anything that affects the heart from an electrolyte or toxicological standpoint is something that we always get concerned about, because once the heart goes into an arrhythmia, it's going to be very difficult to get it out of that state. So hypokalemic patients, hypokalemia is the easier of the two. So this is one, usually patients are pretty asymptomatic with low potassium until it gets really low. You might see some muscle cramping or weakness, maybe cardiac arrhythmias or EKG abnormalities, but again, it's going to have to get pretty low to see that. It's generally not super serious, and the good thing is it's really easy to correct hypokalemia. It's really common in hospitalized patients, alcoholics, patients on loop diuretic therapy, and we just give potassium. Potassium is very well absorbed from the GI tract. There's also IV forms that are easy to give and replace. So potassium's super easy to replace. The one probably trick to it is that if the patient has low magnesium, you have to replace that as well, because it's a cofactor in potassium uptake. If you don't have mag levels that are adequate, you won't have potassium that will be able to replace. So usually we're going to replace both mag and potassium at the same time. And generally speaking, if K is low, the mag is going to be low as well. The standard potassium replacement are going to be potassium chloride products. There are some different oral forms. There's a lot of different tablets out there that are extended release. These are usually really big tablets, like potassium tablets are probably some of the biggest tablets people take. So people might not swallow them very well, and that's okay. Usually the big tablet actually is sort of this matrix of little packets of potassium. Think about it that way. And if you take it, it slowly extended releases the potassium out as it breaks down in your GI tract. Another thing you can do is just mix it in like some liquid and then drink it, and that doesn't destroy the extended release mechanism. The only thing would do that is if you actually like physically crushed it with force. There's IV potassium that's for severe or really low potassium, or simply you can't take anything orally. And IV potassium is still potassium chloride. That's going to be replaced. So dietary adjustments to potassium usually aren't as effective. So if you have low potassium, you can generally just, for example, I remember this guy in my pharmacy class when we were talking about electrolytes, like, can't you just eat like a whole bunch of bananas? It doesn't really work that way. Your body can only absorb so much potassium from dietary sources, and potassium chloride is not the type of potassium you get from dietary sources. It's a different potassium salt. Normal requirements for potassium are about 40 to 80 milliequivalents per day, and usually these are replaced via a hospital protocol, which is nursing and pharmacy managed, so very easy from a provider perspective to order that. And that usually includes the follow-up monitoring, but of course, serum potassium is really essential to monitor. If we overdo it, we're in big trouble, so we want to be careful with that. So hyperkalemia is the more dangerous of the two. Most common in renal failure patients who miss dialysis, but also can happen for other reasons as well. EKG changes are going to be seen, such as a wide QRS complex, peaked T waves, smaller absent P waves, and treatment is basically around getting potassium driven back into the cells. And you start treatment based on EKG. If the EKG is fine, you can focus on just getting that potassium down. If the EKG changes are present, that I list above here, you want to stabilize the cardiac membrane first. So how do we do that? Oops. Step one. So again, if there's no EKG changes, this is really important. I feel like I get a lot of questions about this every year, so I'd maybe take a second to go through this slide a couple of times. Step one, if you don't have EKG changes, you skip this step completely. If you do, so if you see those peak T waves or wide QRS complex or whatever it is, you want to give calcium, and that's IV calcium, either chloride or gluconate. The two different calcium products I think I've got on the next slide. We'll talk about that in a second. But basically, it's just getting calcium into the body fast. And you usually just give a full amp, which is basically a gram of calcium. It doesn't really matter the dose. You just give the whole thing. That's the point. So if you give that, then you'd move to step two. Or if you didn't need to, because the EKG wasn't changed, potassium's still really high, then you just can go straight to step two. So step 2 kind of all revolves around insulin. Insulin is the best way to drive potassium into the cells. So you want to give insulin, but first you want to see what their blood glucose is. If their blood glucose is elevated, you don't have to do anything because the insulin is going to help with that. If their blood glucose is normal or low, then you're going to want to start with dextrose. So you give some IV sugar to prevent insulin from bottoming out, because insulin is going to, of course, cause is replacing or adding to your endogenous insulin, and that's going to cause a drop in blood sugar as well. So we want to make sure we don't compound the problem by having a hyperkalemic patient who is now hypoglycemic. So insulin is going to drive potassium into the cells. You're going to give 10 units of IV regular insulin push, and then you can have some other options. So the other things are all sort of things you can do and are usually done, and don't have as big of an impact as insulin, but may help. So there's sodium bicarbonate, which you can give IV, and that can help drive potassium into the cells. And then albuterol nebulization, actually, treatments can help drive potassium into the cells as well. So generally, the priority here is going to be calcium if you're going to have EKG changes, and immediately after, you're going to go to your insulin, and depending on where the patient's blood sugar is at, you're going to give dextrose or not. Then after that's done, you're looking at maybe giving some bicarb and putting them on a nebulizer treatment. You could give Lasix too. Lasix is usually not done in a severe situation because this should be enough to treat it acutely. Lasix might be an ongoing management thing where you give it to help drop their potassium over time. You can give sodium, or if I should say this as well, you might just skip everything. Like if the person comes in and they're slightly hyperkalemic, or maybe you're replacing their potassium and you overdid it, and their potassium's a little bit high but not terrible, you might just say, well, let's increase the Lasix for a day and try and waste some of that potassium off. That's a way to do it too. Don't have to do any of this. So you can pick and choose a little bit what you want to do, but basically I'm kind of approaching this from a more severe situation where you'd want to go through the whole thing. Sodium polystyrene is generally the thing you're going to give very last. It's an oral agent. It takes about a day to see your full effect, so it doesn't help in acute situations. But if you have somebody who has high potassium and they come in and you do these things, you could give this to them as a more long-term suppressive option to prevent their potassium from being absorbed and then exchanging out their potassium so that you don't see like a rebound spike in hyper K after you do these things, after these things wear off. Calcium chloride versus gluconate, just to highlight this. Calcium chloride is about 3 times the elemental calcium per gram. It's instantly bioavailable as ionized calcium. It's very hard on the peripheral vasculature, so infusing it, you can often blow a line or cause significant pain on the patient and kind of like a burning sensation when you're infusing it. But it is the more, it's the faster option to give. Some people who are in acute arrhythmia or coding because they have high potassium, that's the one you're always going to give. If the person's somewhat stable, but you're starting to see those EKG changes, gluconate's probably the better option, but it's less bioavailable and it's slower onset. It's quite a bit easier on the blood vessels though. All right, magnesium. Magnesium is your molecular stabilizer. It has a number of different functions throughout the body. It's very easy to get in the diet, which is fortunate, but some patients you'll see, well, and specifically kidney disease patients or other types of diseases might be more apt to it. But it seems like hospitalized patients, renal patients are more likely to be low mag, especially if they're on loop diuretics. So our kidney patients are CHF patients who take loop diuretics fairly regularly, likely to have low mag because it's not going to, because it's going to get wasted. Usually our kidneys reabsorb magnesium fairly readily, so we don't waste a ton of it on a daily basis. But if you're on a loop diuretic, you're going to push a little bit more of it out. Okay, low mag, so again, hospitalized patients, GI renal disorders, drug causes, diuretics going to be the big one here. Symptoms can be nondescript, but CV, neuromuscular, muscle cramping type of things, maybe neurologic in severe cases. I honestly don't think I've ever seen anyone that we've said, yep, that was emergency presentation because of low mag. We usually just mostly get concerned about mag because of the potassium replacement goes hand in hand with it. Not that having low mag is good thing. We just generally don't get as concerned about that because clinically, I think you have to get pretty darn low to really see something happen with low magnesium. And it's probably more of a chronic thing than like an acute drop in mag. Anyway, so your goal, if you have signs and symptoms, get them resolved with correcting the magnesium, get it above 1.8, protect your potassium if you need to as well, and watch your underlying causes just like you would with any electrolyte abnormality. Oral options, these are over the counter. Magnesium oxide is available. This is going to be the most common one. It's a immediate release product. There's also this magnesium chloride called Slow Mag, which is a little bit lower dose and delays the release. The problem with magnesium products is they cause diarrhea, and you basically titrate them until the person starts having loose stools, and then you pull back. So it's not the most pleasant for a patient to take. IV mag is a lot easier to give. It doesn't cause, it's a lot easier to give from the patient perspective because it doesn't cause diarrhea. It doesn't get into the GI tract and doesn't affect it like that. We give magnesium sulfate, and it's, again, a lot easier. If you have IV access, generally preferred to give mag in the IV form versus orally, but certainly there's a role for oral replacement as well. If you have high magnesium, this is super uncommon. Usually this would be due to like a acute kidney injury where the kidneys shut down in a fast way, or a CKD patient who's maybe on dialysis who can miss their dialysis. Other ways, maybe overusing magnesium-containing laxatives, which are over the counter. Here's magnesium citrate, which is a common like bowel prep med. And if you are constantly drinking this to get the laxative effect, you can actually absorb the mag and end up with a hypermag state. CV neuromuscular complications, it's really rare to see this, for one, and two, to have complications because of it, but we'll talk about it just because it's the other side of the coin here. If the person has adequate renal function, fluids and loop diuretics IV should take care of your problem fairly quickly. Elemental calcium, gluconate, or chloride IV can cause a physiologic antagonism, especially in the cardiac tissues, that can help prevent some of the CV side effects you might be seeing, and supportive care. So basically, you might see people with really low blood pressure or bradycardia and decreased breathing rates. So that's where the calcium can come into play to help with that. Otherwise, pacing people electrically, using vasopressors to support. And so basically, it's just supportive care like we would any other situation. So there's not really a sure cure for hypermag like there is potassium. Here you're just sort of treating the peripheral effects of it and trying to get it down by diluting it out with fluids and pushing it out with loop diuretics. You could probably get somebody to dialysis if you wanted to, if they're really severe, and then that would pull it all off. So that would be an option too. All right. I had these last few slides on here because last year I went through this in class. I won't do it yet because the quiz isn't done, but if you guys want me to reach out, I did type my logic into the quiz like I would normally, but it's just this is the same cases on the quiz.